With that, we have come to the end of the third session for today. I thank all the chairpersons and the speakers for their insightful and interesting presentations. Now we move on to the final session of today's conference. So to introduce the final set of speakers, I now call upon Professor Dr. Vengadakrishnan, Professor of Medicine, Srihar, Chennai, Senior Consultant Physician and Diabetologist, SIMS Hospital, Chennai, and Dr. J. Ganesh Muruganandam, MD, Consultant Physician and Diabetologist, Nalam Diabetes Center and GG Hospital, Chennai. Please put your hands together and welcome the chairpersons so that they could introduce the speakers. Over to you, sirs.
Good evening, dear T-Club members. So, this session will be done by Dr.D.Suresh Kumar sir, MD F&B Infectious Disease. Welcome you, sir. We give a big hand for him.
Thank you, sir.
And our secretary, sir, will be honoring the speaker. He's a senior consultant in infectious disease, Apollo Hospitals, co-founder of Best of the IDs, 28 years of experience, so much of award and accolades, 40 papers to his name. Over to you, sir.
Thank you, sir. I sincerely thank the organizers for giving this opportunity, and particularly all the chairpersons I know very well, and I know the organizers also well for giving this opportunity. They asked to talk about both HIV, hepatitis B and dog bite all in 45 minutes there. This is very tough job on the last part, so I talk my initial part, that is HIV, then followed by dog bite. Hepatitis B we can answer because my previous speaker also wrote about abdominal pain there. So this is my alma mater I can call. This is where my HIV I learned there. So this is called the Government Hospital of Thoracic Medicines. Everybody who worked in the thoracic medicine, Tambaram, they know this is a famous ward called ward number 28, where in 2004 when I learned my HIV, all beds were flooding with HIV cases there. Each bed is occupied by 3 patients. Almost all opportunistic infections, I learned my medicine, because previously people used to say, when you know syphilis, you know the medicines. Then people came and, AIDS, you know the medicines. Now COVID, we know medicines. The changing happening there. So in 2004, when I learned the medicine through this HIV AIDS Centurium, so this is my disclosure here. I'll begin because this is a 4 o'clock. I know which one is baby. I want to put, because this is a DC club, I want to put whether managing diabetes is easy or whether managing HIV is easy. Which one you consider? How many say diabetes? Leave the COVID part. COVID is gone. How many say that managing diabetes is easiest thing? Nobody? All up. Pre-prandial. Some tea, coffee needed. How many say HIV is easy? I can say HIV is easiest one. The diabetes keep on, you have got all semaglutides and companies are withdrawing it. A lot of issues is going around there. That's none of the company molecule is withdrawing here. So it's easiest to manage. I'll show why it's easiest to manage compared to diabetes here. So even though more people affected, but off late number of people coming down. People are coming down less. So COVID is not over, but COVID still we are seeing cases right now. So my objective is when to suspect HIV in your practice, how to confirm the diagnosis here, what to start. I'll try to summarize and way forward. I'm going to put only case-based only there because this is the last presentations. I know I don't want to bore with the theory right now. Again, I want people to interact because I want to put it in a show, but unfortunately it was not happening. I shown here 4 cases here. Can you suspect which one is probable? Because HIV needs confirmations. We can't say this patient is HIV, whatever knowledge. The famous person in the Government Hospital of Thoracic Medicine, he say, put the tongue out. This is a typical HIV tongue, Tambaram tongue they call, and they put HIV. That's a era gone. But we need to prove the HIV. Clinically, we can suspect, we need to prove it. This is a 26-year-old female, married for 4 years, planning for a pregnancy. Pap smear showed some abnormality. Can you think this person has got HIV positive? How many say possible? Nobody. 65 female, non-Hodgkin's lymphoma, no response to 6 cycles of chemotherapy, hysterectomy 20 years back. Can you think HIV here? Okay, yes, some son. 28-year-old male from Salem, sales executive, fever, sore throat, cervical node of only 1 week durations. Just 1 week. Because of Salem. 30-year-old male, no comorbidity, just herpes zoster. 1 episode. So, which one is all of the above? Usually in MCQs, all of the above, none of the above, always tempted. All of the above? Yes, okay. Okay, we'll come back. Previous history, when a person has got risk behavior, sexual behavior or risk behavior, we think the person has got HIV. Now the concept is slowly changing. These are all the indications. For example, recurrent bacterial infections, unexplained weight loss, infertility, unexplained lymphadenopathy, non-Hodgkin's lymphoma, CA cervix and CA lung. These are all age-defining malignancy. Particularly non-Hodgkin's lymphoma, non-responding to 6 cycles of chemotherapy, we need to think. In fact, the person's husband was got very little fight, and the oncologist didn't know about non-Hodgkin's lymphoma, started chemotherapy. No response at 6 chemotherapy. 7th chemotherapy, he got some suspicions, he asked for it. Then he suddenly turned positive. The husband became too rude to the consultant. Who asked to do this test? I came for non-Hodgkin's lymphoma. Why you did the HIV test? This person didn't do any sexual activity. She underwent hysterectomy 20 years back and she got transfused with the blood that streamed or not, we do not know. That's why she got it probably. But the husband got rude. That's a problem we are encountering. Infectious mononucleosis, chronic hepatitis, fever of unknown origin, always think HIV. This is most important thing. Then how will you do the test? Anybody knows Pulika Raja ke Hate Surma, this campaign? So people who practiced in 2000, 2004, this is a famous campaign, Puli Raja ke Hate Surma. So that's what, people who know a lot of sexual behavior or extramarital contacts, they will ask the thing, HIV will come or not. But previously we used to send this center called VCTC Center, Voluntary Testing and Counseling Center, now become Integrated Counseling and Testing Center. How many private hospitals got ICTC or VCTC Center? Any corporates? I don't think so. In my hospitals, we don't have it. Then how are we going to do the test for HIV? That is most important thing. So this paper we wrote couple of decades back. So what we did, this is in Government Stanley Hospitals, I did it. What I did is when a person comes to the hospital for some reason, because most of the patients got admitted, for some reasons, what we did is we are given an option to the patients. I do all the tests for what is required for you. In addition, I'll do a HIV for you. If you are willing for it, if I give you an option to you, yes. That's called opting in. The person says, I don't want to do the test. Opt out means I don't want to do, we don't do the test. So opting in means we do the test. Out of 192 patients we did, people are opting in for the test. 4 were tested positive. They don't have any knowledge about HIV previously. So 4 new cases we find out by giving an opting out test to the patients. So that means the surgical package, the surgeon wants to do, that gives a lot of HIV positivity. They can identify a lot of patients. That is similar to opting in or opting out. There is no need for ICTC. You just give the option whether you want to go for a test or not. If they go for a test, yes, we can do it. That's most important thing. That is option available right now. So that picks up almost 4 cases picked up and 4 patients puts on treatment. Why we want to test? Previously there is no treatment. When I started my practice in 2003, 2004, there is no treatment available. Only people used to use some Siddha treatment. Then came ART medicines. All my first 250 patients, the CD4 count was 0. Absolutely 0. We started almost all the opportunistic infections, cryptococcal meningitis, toxoplasma, everything we have seen. Because after starting ART, all immune reconstitutions happened. But right now 4 cases, if you start putting on ART, the risk of transmission to other people can cut down. That is the point of doing HIV testing. Because people do the HIV test and they said, I don't want to treat, go any other hospitals. Right now, good treatment is available, you can manage. We got almost 20 to 25,000 patients in our hospitals. We do CABG, we do bypass, we do replacements, we do transplants also. This is what we did for HIV patients. There is no stigma. In my patients comes to my OP, almost 20-25 patients sitting in our OP, 3 or 4 is HIV positive. Who is HIV positive, who is HIV negative? Even my secretary doesn't know. They can see, they can go out. That's what they're doing it in our hospital there. Okay, this is infertility. I told infertility is one of the indications for doing HIV test. This is a 41-year-old male and 36-year-old female from a respected family being investigated for infertility. After attending the lecture, the gynecologist went and did a HIV test for the persons. So what test you want to do for these patients? What test you want to do? How many say HIV ELISA is good? Otherwise, I got a rapid CAR test. I got a rapid CAR test in my clinic. HIV CMIA, clinical chemiluminescence assay. What do you want to do? Or Western blot, that's a confirmatory, straight away hit, or all of the above. So this is a test right now. So they did a test, I do not know, but HIV is negative. So sitting in the back, believe my words or believe the chairman's words, the HIV is non-reactive, all are non-reactive, sorry. So what are going to do now? Clear for infertility, all were negative. Okay? Clearance? Are you happy? Or you want to ask for a risk behavior? Or you want to clear for infertility? How many says choice 1, clear for infertility? Negative. Call the lab. I will call the lab. Why the call the lab? This is a problem. Within a month later, July 2017, test done, negative. August 2017, within a month later, all tests is positive. By means of ELISA, by means of chemiluminescence assay, by means of rapid test. whether a person got acute HIV within a month. Why I was not suspicious? This is why the problem. So what is the method? They did nothing. They said HIV. Antigen method, antibody method, rapid test, nothing is there. So that's why I said call the lab. That is why the very important thing is we need to do the test in a good quality lab. If you don't do in a good quality lab, this is going to happen to you. So the person did in July, but came back on August, all 3 is positive. All 3 is positive. So what are you going to do now? Postpone the infertility or postpone the plan for child? How many say this couple doesn't require child? In our populations of 20,000 odd patients, 500 odd couples are there. Husband positive, wife negative, wife positive, husband negative. They have conceived, they delivered, none of the child has got HIV. So we prevented the HIV transmission, that's fine. So can you call this is an acute retroviral syndrome? In our practice, acute retroviral syndrome is very difficult to diagnose unless we got a strong suspicion. The case what I put, Salem, the person is a sales representative, staying away from the family, maybe doing the risk behavior. He got fever and cervical node. Possible acute retroviral syndrome, we need to think based upon the history. That is why in medicine, history taking is most important thing. The Salem history, travel history, staying away from the family, all give the clue. So don't say the person is living in Chennai. I want where he is living, whether with family or not, this is more important for me. This is what we need to do. But acute retroviral syndrome, the problem is HIV ELISA will not be negative. Only we need to do the viral load testing, but here the HIV testing is positive. So something is fishy. I'll come back to this case a bit later part of it. So acute retroviral syndrome, you need to have a strong suspicion. Unless you got a strong suspicion, very difficult to diagnose. Antibody is not going to help out. If you think acute HIV, do the HIV viral load. So this is the logic behind it. HIV viral load will go up, then go down immediately. That point of time we can able to pick it up. Antibody will take some time to form, so don't do antibody to make a diagnosis of acute retroviral syndrome. So this is acute HIV, typical fever, person has got some cervical node, weakness, tiredness, typical acute viral fever. Any acute viral fever, if risk behavior is there, put your money on acute HIV. Similarly, mononucleosis like illness, HIV is one of the differential diagnoses we can offer. So this person now what will you do? We know the person has got, the test is positive. So what will you do now? Whether you want to repeat the test in your lab or you straight away want to treat the person. Viral load and CD4 count, look for other viruses too, or repeat the test at government hospitals. Whether you want to rely our lab, because the person, it's not our lab, this is also outside lab. So what are you going to do now? Repeat the test at government hospitals or confirm with Western blot. Confirm with the Western blot. A lot of noises I'm hearing. So those who wanted Western blot, can you interpret the Western blot? Western blot I read out there for people sitting in the back because of the poor quality of the slide. So HP P31 is positive and person has got GP 160 is positive. 2 antigens are positive. What do you call? The person has got HIV positive? Yes. That's a bit difficult to interpret the test. I voluntarily cut the paper till this part. I'll give back the back. So we need to have 2 envelope antigen. GP for GP1, person should have GP 160 and GP 120. Both should be positive. Here GP 160 alone is positive. Similarly, 2 envelope antigen along with 1 protein antigen. It's a bit difficult to sort it out there. It's a bit difficult. Now I just given a thing. HIV is indeterminate. This is a full report. Whether this person has got HIV or HIV not there. So the bottom line why I am presenting this case, when the person tested positive for HIV, don't jump and say you got HIV. A lot of surgeons burn the finger. When they did the ELISA positive, the family come and fight with them. How come you tell I got HIV positive patients? So we need to always think it can. False positives can happen. So the problem is whatever lab, whatever hospitals, false positives can happen, keep in mind. So always a differential diagnosis of false positive, keep in mind. And HIV Western blot is an outdated test, we don't do it. It creates more confusion, providing solution to me there. Where I use for Western blot to differentiate HIV1 and HIV2, previously I do it, but nowadays I stopped doing HIV Western blot. That's what guidelines also. This is latest CDC guidelines. No mention about to do the Western blot. They need to do a good quality lab, ELISA or CMLA, chemiluminescence assay. If it is positive, we can figure out 1 or 2 by latest assays. The latest assays is called both antigen and antibody assay. We can able to differentiate it's positive or not. So the story is not hence here. So the story repeated here. This is in Apollo, we did the test. The microbiology lab put EQ vocal. So the HIV positive means a lot of other conditions. HTLV1 can cause the similar presentations. Sometimes for unknown reasons it remained. This person remained almost 6 months. We repeatedly tested. It remained EQ vocal. But if I did the viral load is not detected, not on ART. So this person has got false positive HIV. We finally cleared the person for infertility workup and finally conceived. They got child, the child is not infected. Every 6 months he is doing still equivocal. So some patients are their equivocal still continuing on. So HIV is not that easy, particularly interpreting test is most difficult part. Always tell if it is positive, try to confirm with other methods like viral load, or we need to check the ID-NAT method. ID-NAT is a qualitative method. Viral load is a quantitative method. Keep doing it, that's most important. Now the second part of HIV is, first part is a diagnostic part. I told Western blot is an outdated test. Do ELISA or CMLA. If it is positive, pre-test possibility is high, you can say. If you want to confirm, confirm with the viral load. That's the point I'm taught you now. The second part now is when to suspect opportunistic infection. This is HIV positive, confirm, no doubt about it. So what is ART here? What is opportunistic infection here? My chairperson hit the nail. PCP there. So why he said PCP? When the person has got typical ground glass opacity, more of perihilar involvement, peripheral sparing, HIV patients. What is the clue here? I want to know the CD4 count. And the CD4 count is less than 200. Opportunistic infections are more. So to approach an opportunistic infections, we need to know the CD4 count. Viral load is very difficult to say. CD4 count. So if the person has got this one presentations, I need to know what is the CD4. If the CD4 count is more than 200, I can't put my diagnosis of PCP here. I put the diagnosis of the pulmonary edema or something else, I need to put it, not the PCP here. Since the patient has got CD4 count of less than 200, I need to put my diagnosis. That's why I put start cotrimoxazole to the CD4 count. That's most important thing. So for opportunistic infection, CD4 count is very vital. That's the point I'm making here. So we need to know the stage of the patients. For example, when the person has got more CD4 count, no symptoms, usually after the HIV infections, one episode of viral, then they go for asymptomatic phase for 5 to 6 years. Sometimes it can go up to 7 years, sometimes go up to 2 years. That asymptomatic phase is very difficult. Then simpler symptoms, for example, oral candidiasis, some skin lesions, herpes zoster, this is called category B. Category C means age-defining illnesses. Esophageal candidiasis. For a US person, pulmonary TB itself, age-defining. For India, it is extrapulmonary tuberculosis. I need to think about it. So this is what we need to do, the classification system. I'll show a couple of pictures. What is the diagnosis here? Anybody? I know it's a pre-prandial, pre-coffee time, I know. So the dictum is, sir, you need to ask what is the CD4 count. If the CD4 count is more than 200, this is molluscum contagiosum. The CD4 count is less than 200, cryptococcosis is possible. So all depends upon the CD4 count. It's not jumping. This is easiest one there. Herpes zoster. So when a person is a young individual without comorbid, for example, the person is less than 45 years, not a diabetic, not on immunosuppression. One of the case I put 30-year-old herpes zoster. Why the 30-year-old person get herpes zoster? So if the person has got herpes zoster, think about HIV. If the person has got multidermal herpes zoster, we need to think about it. Less than 45, no comorbid, herpes zoster, please ask HIV. That's one of the defining conditions. This is a wart, genital wart we can have. These are all called stage B or CDC-B stage there. These are all mild infections, papular pleuritic eruptions. This is out. This is oral candidiasis, typical. We can put the diagnosis immediately. If the person ask any steroids inhaler or any diabetic poorly controlled, we need to ask for HIV also. So this is a wasting. I never see this type of cases now. We are seeing the other end of spectrum. People are obese now. We are not seeing the wasting. The spectrum is completely changed now. And these are all the typical age-defining conditions. Toxoplasma. Then person has got diarrhea means isospora, cyclospora, cryptosporidium. These are all the things I need to think about it. This is a beautiful isospora we can able to see, and toxoplasma and PCP I can show the thing. So these are all age-defining conditions. So once you make a diagnosis of HIV, the next step is what opportunistic infection is going to patient is suffer. That's most important thing. Don't jump. I saw a patient 1 week back. The CD4 count is 10. The person has got very high viral load. Immediately the person referred to me, doctor, can you start the ART? Can you start the ART? I said, ART not in a hurry. HIV is not going to kill the patients. Opportunistic infection is going to kill the patients. Without identifying the opportunistic infection, if you start ART, that kills. That's what happened to me in 2004. That point of time, for me, there is no ART. The person's CD4 count is 0. I can't wait. So I started ART. After starting ART, the people lose their vision. So many CME retinitis. We lost the life because of the cryptococcal iris. We lost the person's CME. Almost all the opportunistic infections immediately jump back. That is why we said opportunistic infection, treat first. Don't jump and start ART immediately. Particularly if you think something on the brain, give some time. Treat the disease. Person recover, you can give the ART. That's most important thing. So these are all the basic workup we need to do. On CBC, on renal function test is more important. Viral load counting and CD4 counting. Look for other HIV. For example, hepatitis B, hepatitis C, syphilis, RPR, TPHA, and TB screening also mandatory nowadays. So the principle in HIV medicine, opportunistic infection is a killer. HIV is not a killer. So we need to treat the opportunistic infection first, then only touch the HIV. We can wait unless the CD4 count is 2. That's why the consultant who referred to me keep on jumping, sir, why don't we start one more opportunistic infection? Yes, at least 2 weeks of opportunistic infections, I justify to start antibiotic. So these are all the medicines. People worried, you said diabetes is easy to treat, HIV has got so many medicines. Why you said this is easiest thing to do. Don't get confused about these things. So we need to know, combine 3 different mechanisms. 3 different mechanisms I need to combine. So the 3 different mechanisms turn to be only one pill. It contains 2 NRTIs, tenofovir alphenamide, emtricitabine, along with dolutegravir. That's called integrase stand inhibitor. So we need to combine 2 antiviral depending upon the different sites, but all combined and come as a single pill. When I started my practice, I used to give 12 to 20 pills a day, but now it's only one pill. What is the cost of the pill? Hardly 30 rupees a day. Hardly 30 rupees a day. So per month it's 900 rupees. Once in 6 months. It's not a diabetes. Every month you need to check. You need to give insulin. Nothing. This is once in 6 months to once in a year test, along with 1 tablet a day. That is 900 rupees. Which one is easy to treat? HIV is easy to treat there. So don't get confused. This is what we need to do right now. So this is a combination we use. One NC, integrate stand inhibitor, along with 2 NRTIs. One is called Bictegravir. We can use Bictegravir or use dolutegravir, along with tenofovir with emtricitabine. All comes as a single pill. All comes as a single pill. That's more important. So the target, we need to reduce the viral load to be less than detected. That's most important thing. That's what we need to do. And CD4 count, we need to improve more than 200. Till the CD4 count crosses more than 200, cotrimoxazole prophylaxis is required. When the CD4 count is less than 50, we need to provide MAC, Mycobacterium avium cellular complex prophylaxis also needed. So this is most important thing. Can you solve this puzzle at 4:30 in the evening there? Housekeeping staff, after sustaining a needle stick injury, he came back to you and saying that the room where I clean and where I sustained the needle stick injury, the doctors are discussing HIV. He overheard your talks. The housekeeping staff is a smart guy. He said the doctors are discussing HIV, but the person declared dead and the person's body is removed also. He sustained a needle stick injury and bring the needle. This is a needle. When I cleaning the room, I got stuck. What will you do now? And you do the test, turn to be HIV positive. He bring the needle and he says, I got needle stick injury. The doctors were discussing. I was cleaning the room. I was overhearing HIV. I do not know what they're discussing, but they're talking about HIV. What will you do for this person? Counsel him or provide HIV care free of care throughout his stay in your hospitals. HIV one prophylaxis is tested positive, sir. He immediately came back and the nurse, ICN got panic and did the test. They turned positive. When he claimed the needle stick injury, that day is positive. So the bottom line is, again, chairpersons are nailing it. So when a person sustains needle stick injury, the first thing you need to do the baseline test. The baseline test indicates the person's past infection. Because right now the incubation period is cut down. Even with the advanced test, is 14 days. Even if you do IDNAT, nucleic acid amplification test, 7 days. This person is smart enough. He is known HIV positive. He wants to gain benefit from the hospitals. Immediately he says, I sustain needle. That is why all the hospital staff sustain needle stick injury. They need to come and report. If they are not reporting, the blame is on them. Suppose the person reports, I do the baseline test. It is positive. I said, already positive. This is not going to be an incubation period short. It relieved. The ICN was panicked. The infection control nurse was panicked. Sir, the person turned positive. What we need to do? I said, do the baseline test. Baseline is positive. The person is positive. 4 weeks later, that is more important. 4 weeks later is more important. This is common scenario. These people won't sleep there. They go to Pattaya, do something and come back. Sir, this is 16th day, this is 38th day, this is 40th day. Google says HIV is still positive on 68th day. Google says 180 days also positive. They won't sleep you. Ideally, psychiatric counseling is needed for this type of people. But this is a huge market. So this type of people, post-exposure prophylaxis up to 72 days. So we need to know what is the risk. The source is positive, the risk is maximum. When the source is unknown, the risk is minimum. So we need to know what sort of source. Anal sex has got maximum risk compared to vaginal. The person who's doing a receptive sex has got more chance of picking up HIV. Receptive partner is more vulnerable compared to insertive partner. These things we need to remember. One fellow who did oral sex keep on coming and asking me, sir, this is 180 day, this is 160 day, he's keep on counting it there. That's chronic there. So we need to know blood transfusion maximum risk. Sexual risk is only 0.03. I can say 1 in 300 cases chances of picking HIV is there. Not every case of needle stick injury, every case of sexual exposure are going to pick it up. And we need to know the timeline. 72 hours is a golden time. We start post-exposure prophylaxis, it will prevent you. Unless if you start late, it will not work you. What drug? The same drug. The same tenofovir alphanamide, M-tricidabine along with dolutegravir you can give. The person taking the same medications, the viral load is not under control, I need to change the medications. The source person is not taking any medication, this is an ideal drug, we can use it. So this is what we need to know. The person is pregnant, for example, the nurse has got needle stick injury, they got panic. They are breastfeeding mothers also. The nurse may be a breastfeeding mother. So at that point of time, we try to avoid breastfeeding till we sort out the 4 weeks time. Ask them to take the medications, avoid the breastfeeding. That's most important thing. And similarly for a male partner, young people, they need to avoid sex or they need to use condom during the time. So this is what most important. Right now, this is other patients, 28-year-old male, ART and good control. So they want to conceive. I told my 500 people, HIV positive, all conceived. That time there is no pre-exposure prophylaxis also. All conceived with good clinical control. So U is equal to U. Undetected is equal to untransmitted. When the viral load is not detected, they can conceive. Because viral load detected, the chances of transmission to the fetus is high. When the viral load is not detected, they are not going to transmit the disease to the fetus. So don't say the person, I want to go for in vitro fertilization, so I want to wash his semen. Nothing, we are doing it. If your viral load is under control, you can go and conceive. Nowadays, we given options. Take pre-exposure prophylaxis. The wife's negative, ask her to take the medications what same husband is taking. The husband is till the conception. Conceive is over, we can stop the medications. That's what we can do. 1 dose of tenofovir alphanamide will not affect the child. So that's what. Now pre-exposure prophylaxis in US is available. Long-acting injectable agents that works for 6 months. If you give 1 injection that protects you for 6 months, they can, in between time, they can pregnancy, they can have it also. People frequently going to Pattaya also, they take the injections. If you are a surgeon, you are going to sustain more needle stick injury, you can also take this pre-exposure prophylaxis, going to be launched in India soon there. This is a long-acting injectable agent. 1 shot will work for 6 months as a prophylaxis. Treatment, we do not know exactly how many months will work. This is called the pre-exposure prophylaxis. People who got vulnerable behavior, yes, we can take it. This is a hot topic for next DCC-Con. I can talk about what pre-exposure prophylaxis we can provide. PEP is always difficult. Failure can happen post-exposure prophylaxis. Pre-exposure prophylaxis is a way forward. That's most important for you there. So this is another interesting stuff. 27-year-old male getting married next week. He got secondary syphilis, he got HIV. After the engagement is over, marriage is next week. What will you do now? Sorry, sir? 3 days. But what is about whether you call the girl and say, cancel the marriage? Yes. Call off the wedding. What happened to this case? Initially they called off the wedding. Then finally they again remarried and they have a child also without notice of thing, without any transmission to the child. But later the child is born, they got divorced. That's another issue there. So that's a problem there. So this is ethical questions we can't difficult to solve. But we can say this is a very difficult ethical questions. The person should give the pros and cons. I give the family, both the family are invited, told the pros and cons. Initially they cancelled the marriage. Later they went again, some other new date they got and they got married. They got child also. After a child is born, again some issues, they got divorced there. So previously when the examiner asked the last question, to tell the answer, tell whether you are going to pass this exam or not exam, usually Dr. Paranaman will give a clue to you there. Say whether you are going to pass these exams or not. Asking the last question, what is the prognosis of rabies? Or what is the prognosis of these 4 diseases? If you ask, people say, my prognosis in exam is gone. I need to go and study for the next exams. That's what we need to do. This is 1981. But we are living in 2000 onwards, not 2004 onwards. Now this is a chronic manageable disease. Hypertension, diabetes. That's what people say, doctor, how long I live? One beautiful paper in Lancet answered the thing. The average age of the diagnosis of HIV is 30 years. If you start ART, they live 37 years. 30 plus 37 is 67 years. Average life expectancy is 63. So he lives more than the ordinary life expectancy. That's what we used to say. Your life is same. Not even 1 day will go down, provided you take the ART medications. So normal life expectancy, counsel the patients well. That's most important. Is there any cure? So far, 7 people have got cured, but how they got cured? They got blood cancer, they got chemotherapy, radiotherapy, they got a donor, the donor has got a mutation, that mutations prevented the HIV coming back. So to get cure of HIV, get blood cancer, get chemotherapy, radiotherapy, get a donor, the donor should have mutations. So that's why they're working on it, but unfortunately they got the principle, so they started the phase 1 trial soon, maybe in another 5 to 7 years. For example, HCV has got a cure, HIV has got a cure shortly in another 5 to 7 years. It's possible. Right now a lot of research is going on, possible there. So whatever I told, we wrote in a book called, what is a step 1, what is a step 2, what are the things we need to do. This is called ID algorithm. All the steps we have written, simplified your job. So this is a book there called ID algorithm, so you can get it right now. What is a step 1, step 2, step 3, not only for HIV, for all cases. Hepatitis B, same thing there. Only we need to give immunoglobulin for the post-exposure prophylaxis. HIV post-exposure prophylaxis with the tablets. This is HIV, we can give it there. So if you know HIV, whether your patient is going back with the same car, you can earn money there. That's what I'm telling it. Thanks for the wonderful opportunity. I take a couple of questions there before starting the other presentation.
Thank you very much, sir, for a wonderful presentation.
Thank you,
I
sir.
think a lot of new points, and what all points were forgotten over years also you have cleared. And just by telling that you have got an injectable exposure prophylaxis which lasts for 6 years. This is really a new point, because we previously used to give only tablets. And of course you was told about so many things like,
Which one, ma'am, sir, come again? If the wife is negative, they can, till the conceive, they can take the medications. Once the conception is conceived, pregnancy is confirmed, they can stop. But the lady can stop, the husband need to continue. After that, they need to go for a protected sex with the condom there. Till the conception, they can. But after the conception happen, why they need to go for unprotected sex? Even though it's safe, undetected is equal to untransmitted, but risk is 99.99, 0.001 is there. The person has to be continued, the person negative can stop the medications, because fetus can, theoretically, but practically don't, theoretically yes.
So regarding the transmission, needle prick is more transmittive, or this sexual transmission is faster? Because 1.03 you said for a sexual transmission, for needle prick is 0.1.
Anal receptive sex is more risky compared to the needle stick injury. Particularly in the needle stick injury, I'll ask one question: who is most, the needle stick injury is more common with surgeons compared to physicians. But who is going to get HIV, surgeon or physician?
Physician. But surgeon always does the test before surgery.
The two things is there. So the point is, the surgeon always uses glove. They use a personal protective equipment, 1. 2, the surgeon uses a solid needle. The solid needle won't stuck. Whatever suturing needle is a solid needle. The physician uses a hollow bore needle, injecting needle, and the physician never uses glove for giving injections or something there. So the physician, even though getting needle stick injury is less, but the chances of picking HIV is more. Surgeon, the chances of needle stick injury is more, but picking HIV is less because of the glove, because of the solid needle. So this is a principle we need to know. Regarding your question, sir, anal receptive sex is more risky, then anal insertive sex, then vaginal receptive sex, then only needle stick injury, sir.
Yes, yes.
I have never seen a needle stick injury positive patients, but couple of healthcare workers, they are positive. We really do not know some needle stick injury or not. But in my practice, after giving a post-exposure prophylaxis, none of them get transmitted the infection to me there. But after positive, they come back to me. How they got it, we do not know. But after the needle stick injury, they reported to us, given a post-exposure prophylaxis, none of them transmitted it. None of them got disease there.
So one of the point what you learned today is that whenever patient comes to fever, look for the cervical node. If it is positive, look just for HIV. Because acute viral syndrome, HIV syndrome may be detected by that. We can do a viral load, not the ELISA or of anti-serology test. That's a wonderful point. And also you told about the whenever you see suspect HIV, and in addition to the serology, you do always CD4 count. That will help you to whether opportunity infections are prone or not. So wonderful presentation, sir. Now we will go for the next presentation.
Finish it, sir.
Next, yes.
Thank you for that. Yeah, slides.
Sir, continue, sir. The next
Yeah,
one.
I'll finish it, sir.
Dog bite.
Because last speaker is there, so I want to finish a little early there. Can you have the slides, please? So this is a bite there. So I'm biting at 4:30 in the evening, I know. So I don't bite, so don't worry, you can sit here. This is a yearning of an ID doctor. The least yearning specialty is infectious diseases. We try to solve the problem, we don't make money. The person who make the money, like I hope no orthopedic surgeon is sitting here. So they make money by putting a lot of implants, but we solve the problem of implant-related infections, and we don't make money there. So this is not, they asked to specifically talk about the dog bite, but a couple of principles I want to teach you. This person has went to Marina Beach for a walk, horse bitten her. That small kid managing the horse asked to bring for the horse for a ride. The lady said, but before that the horse bitten the lady. What will you do? Whether ARV is needed for a horse bite? How many say yes? Horse bite needs. A lot of people are active. That's good sign there. Very good. So yes. So India is common. Why we are talking this? Rabies is India. If you see any map, India is always red. Number of death, number of parts, almost except Goa, most of the places in India, the rabies dogs are surrounding, and every street has got 4 to 5 dogs, and every dog will chase you if you go by two-wheeler or by walk. Sometimes they're chasing right now. I'll come back. That's why we are discussing right now. So leave this part. So why I am discussing this is a reason. Last 1 week itself, all medical specialists, one of the general medicine specialists called me, my maid is bitten by a stray dog in the face. Can I give the rig in the face? How many say rig? Rabies immunoglobulin can be given in the face. Okay. This is an hematologist who is walking in a park. One dog came close to him, but he is not sure whether it's bitten, licked him, nothing. So whether we give him prophylaxis to him? Okay. Because this is a hematologist. GP, I have consumed the milk of a cow that was bitten by a rabid dog that came to later. The cow died after 3 days or 4 days. He has taken the milk from the cow. It's a boiled milk. We want to give, but the animal was died of rabies. Cow. Intensivist, I intubated a patient with altered mental status. Lot of secretion is pouring around. Now the patient was diagnosed as rabies. I intubated, splash happened, I was not wearing a mask. This is an emergency intubation. Human to human transmission. So this is why we are discussing today how to possible there. So the Marina Beach case you already answered, yes, except few animals. For example, rat bite, squirrel bite, birds, human, most of the human, I'll come back to the human part little later of it. So except these 4 things, human bite does not require rabies, rat bite, squirrel bite, and if it is a bat. In India, bats are not transmitting. US is a different scenario. In India, bat will not transmit the rabies to me there. Bat will transmit Nipah, but bat won't transmit rabies in India. So these animals don't expect ARV. You can give TT, but don't expect ARV. So this is another thing there. This lady has got a pet of cat. The cat keep on biting her. This is a bite. What will you do now? She's playing with the cat. This is a provoking the cat. Just playing is a provoking. What do you mean by provoking? Anybody can define what is provoking? This is a definition. Walking past the dog is a provoking. You just walk past the dog, that's a provoking to the dog. So it's very difficult to say what is provoking, what is non-provoking. It's a bit difficult. So don't ask this type of history. You can ask the history, but what history we need to know. Similarly, people say my dog is a pet is a vaccinated. The dog is a vaccinated. So the animal is vaccinated. How far you are going to believe the vaccination is going to help you out? For example, so many people taken hepatitis B vaccinations. How many of you produce antibody? Similarly, during time of COVID, everybody taken the vaccinations. After vaccinations, how many of you got COVID? So the vaccination has got limitations. Not all vaccination is going to protect. I am not telling. This is an Indian rabies guidelines. Vaccinated, non-vaccinated, don't believe. Provoked, unprovoked, not believe. Because Indian dogs are unpredictable. That's what they're telling by Indian guidelines. I am not telling. Indian dogs are unpredictable. So this is one of the railway staff. So she is coming back from her office. Similar bite. The dog is roaming in the general, most of the public sector hospitals and offices, dogs were there. So the dog is keep on biting so many people there, and she is a victim this time. So what are you going to do now? Because the dog is keep on biting the people. Same dog. Just leave it. Take vaccinations, don't take it there. Whether we need to observe the dog, what is the principle? Usually the animal has got incubation period. People always confuse with the incubation period and the disease. The dog might have an incubation period of either 0 day to 3 months or something there. But once the dogs start behaving abnormally, the dog won't be alive more than 7 days. That's why we need to observe the animal. So once the dog manifests the symptoms of rabies, behaving abnormally, biting other people, catching the hair or something, behaving abnormally, that point of time the dog and cat, this rule apply. 7 to 10 days we need to observe the animal. If the animal is alive, the chances of rabies in the animal is 99.9. Medicine, it's not black and white, it is always grey. 99.97%, the animal is not having rabies. That's most important clue to me there. So observing the animal. So what questions I need to know for a rabies case, whether the animal is a stay one or pet one. Stay one very difficult to track, pet one easy to track. I need to observe the animal for 7 to 10 days. Whether the animal is a dog, cat, rat, that's what I need to know. If I know the need, I need to give the prophylaxis or not. So the first part in history taking is over. So this is one of the Swiggy delivery boy. He is bitten by a small puppy. Scratched it there. What are you going to do now? Only scratched by puppy, very small puppy, hardly 10 to 15 days. Chances of getting rabies is there? So we can't say whether it's a puppy or whether it's a big dog or not. Whatever animal, it's a dog means dog. Whether it's a puppy or kitten or something, I don't mind that. So the dog is a dog. Whether the immunity, mother has got infections, mother has got vaccination, transmitted the immunity to the puppy or kitten, we do not know. So animal is animal. We need to know the category of wound. This belongs to category 2 there. Even though category 1, the skin is intact. Even though there is no bleeding, but the bite mark or scratch mark is there. People say this is a scratch. Nail only scratched it. Why? When the rabid animal behave abnormally, the saliva pours on the nail. So if the animal scratches, risk of transmission is there. Don't say bite and scratch. Bite and scratch has got no meaning. Both can transmit the rabies viruses because the animal behaves abnormally. Saliva pours on the nail. It scratches means it can transmit the disease to you. A cow was bitten. Usually the gastric acid will kill the rabies virus. The chances of surviving is a bit low. So don't say cow's milk I've eaten, meat I've taken, whatever milk or meat, whatever things, usually. For example, the butcher has got a risk. For example, he can expose to the blood or he expose the secretions. But other person, the risk is nothing. Milk, because most of the time we boil the milk one. Second thing, we consume through the gastric acid will take care of it. So the risk is very nothing. Unless the person handling the butcher job type of things, the risk is there. So this is a person already completed the vaccinations 3 years back or 5 years back. Again bitten by the dog. What will you do now? You give vaccinations or immunoglobulin? The most of the emergency people call, I want to give immunoglobulin. This is a significant bite. They want to suture also. But the previous vaccinations, one time the person is vaccinated, no need for immunoglobulin. The person never vaccinated, immunoglobulin. Particularly if you want to give at the site where you are going to suture, definitely you need to give it there. The next question is suturing can be done or not done. Whether this wound is need to suture or not. Rabies bitten dog. The ear is gone, the scalp is open, whether you want to suture. If needed, yes, we can suture, but don't put a tight sutures, loose sutures. Put an immunoglobulin to the person not vaccinated previously before giving the sutures. So rabies immunoglobulin, you can suture it, but not a tight one. You can do a loose sutures, we can do, because we need to stop the bleeding. We want to protect some, for example, one of the case I'm going to show in a later part of it, you can see this one. Then people always say, I have taken, this is what we need to do. Whether the animal is a stay animal or pet animal, whether it's a dog, cat or rat. The third thing is what category of wound, category 1, category 2, category 3. Category 1, there's no need if you are able to observe the animal. Category 2, ideally we give the vaccinations, observe the animal for 7 days. Category 3, never vaccinated, give immunoglobulin along with the vaccinations, and if possible, observe the animal. This is a simple logic we can do. Lot of guidelines, this is the guidelines from WHO I have taken there. You can see. So what category? Category 1 means intact skin. This is category 3. Again, this is a young female child bitten by a stray dog. That dog catch hold of the child for a face and drag it for 2 feet. Not 2 feet, 2 meters. So the child was bitten not only in the face, scalp. For a female child, if you leave alone, scar will happen. So we need to do the thing. That point of time, the CM was involved. This is a real case from Kanchipuram. They shifted under our care because of this one. We provided a care there. This is long time back. So this is category 2. This is category 3. All bite. For example, wild animal straight away category 3. Whether it's a monkey or whether some wild animal, put category 3 bite. So this is what we need to do right now. So this is a scalp also. Coming from school, how many want to suture? I told suture, if needed, you can do suture as per the Indian guidelines. But put immunoglobulin, loose sutures, not a tight sutures. WHO guidelines says yes, usually say no, but if the bleeding or cosmetic reasons, yes. For a small wound, don't suture. If it is a cosmetic reasons or bleeding, yes, you can suture it, if needed. So the railway staff, what are going to do now? So she received 1 dose of intradermal. In railway hospital, they given intradermal. But right now she doesn't want to go to railway because waiting in a queue, taking a lot of time. She want to come back. You are not comfortable in giving intradermal. Can you switch over to intramuscular? First dose intradermal, second dose intramuscular? Practical one. How many says yes? Because I can't run the show. How many says intradermal, intramuscular? If needed, yes, we can change over. There is no differences between intradermal and intramuscular. Intradermal, why? Government sector, it saves a lot of vaccinations. 0.1 ml is required. With 1 ml vial, we can give for 10 people. For intramuscular, intradermal has got good immunity also, but we need to have train. We need to have skill. Without train, without skill, don't try intradermal. If you got a good skill, you are trained there, yes, we can give. Otherwise, intramuscular is a good thing, but intramuscular we need to give more volume, so costly is there compared to intradermal. But the efficacy wise, it won't change. If you are not comfortable, give intramuscular, you can change over it. So this is a paper changing then intradermal to intramuscular. There is no major differences. Can we change? Yes, we can change. That's what guideline says. Then when to give, people want to know whether monoclonal antibody or immunoglobulin. Government hospitals, equine immunoglobulin. Equine immunoglobulin, they use it. Both equine and human immunoglobulin are effective. But what is the difference? Equine immunoglobulin, anaphylaxis is possible, so observe the person who has received it. But what is the differences between monoclonal antibody and immunoglobulin? Both are same. In fact, monoclonal antibody, the titers are much higher, but the cost is also a bit low compared to human immunoglobulin. Human immunoglobulin, 1 vial of 300 units is costing around almost like a 1 person of a 60 kilogram man. If you want to give immunoglobulin, it costs around 15,000 to 20,000. This is much cheaper. Is there any data? This is one of the big RCT in northern India. They showed monoclonal antibody. The titers are much higher. So monoclonal antibody is accepted now, not necessarily immunoglobulin. You can give antibodies. Monoclonal antibody can be tried. And this is one of the person, unfortunate person. Problem is he's a shop owner. What happened in front of his shop? One of the dog chased bitten a small school child there. So he chased the dog and he killed the dog. During the attack, the dog couple of times he fallen over the child. But the child went to the government hospital, taken the immunoglobulin vaccination, the child survived. This fellow thought, while chasing the dog, I caught fall in the ground and sustained some injury, and he never gone to the hospitals. But couple of times the dog passed over him and scratched also him. He thought it is because of the abrasion he sustained in the chasing event. He doesn't take anything there. Unfortunately, 2 to 3 weeks, typical hydrophobia, he landed. The hydrophobia landed. He became very anxious. He became sort of depressed also. Why I got this disease? Because the child I saved it, but I am not able to save myself. So what happened in the depression? He started biting the staff nurses. So what will you do? I said human to human bite is not possible. This is a rabid hydrophobic man going to die in a couple of days. He started bitten a nurse. What will you do now? The intubated anesthetist, I am asking about it. This is a bitten by a rabid man. What will you do? Definitely I need to give the prophylaxis. So exceptions are there. So don't say always it's not possible. It need to be done. That means it need to be done. That's what we given. Immediately my housekeeping came. I went and cleaned the room. I also got exposure. We said no. So don't think that bitten, intubated people theoretically is possible. Rational is if the virus chances of getting in is possible, yes, we need to give. Otherwise it's not possible there. This is MMWR. We need to do the risk assessment. People intubated, people bitten by a rabid persons, yes, chances are there. In the street fight, school fight, children bite each other. Don't give rabies prophylaxis. Only TT is enough there. So that's what more enough. So obese person getting married next month. He wanted to know all vaccinations. Can pre-exposure vaccinations, rabies included? Who are all take the rabies vaccination? So people are working for a Swiggy, Zomato, people are working in IT industry, coming late night with a two-wheeler, take the vaccination. All veterinary doctors, they take the vaccinations before joining it. All US cousin traveling India, they need to take the vaccinations before coming to India. Why? All Indian streets contain dogs, all Indian temples contain monkeys. So they need to take the vaccinations before coming to India. This is the recommendations of the US CDC. So if you think the risk of bitten by a dog is very high, take the pre-exposure so that immunoglobulin is not required. PEP is always problematic because immunoglobulin costs everything. Pre-exposure, continuous risk. For example, the person working in the veterinary industry, yes, people are constantly exposed to the bite, they need to take it. So pre-exposure prophylaxis is required. The same algorithm book contains step 1, step 2, step 3 is also available for you. This is called WAT approach. What sort of animal I am dealing with it, what sort of bite it has got, whether we need to give the wound care everybody. Antibiotics for cat bite is more required. Rabies is selected individual. Rat, human, squirrel not needed. TT for everybody. Antibiotics. So these are all things available in my book. There are antibiotic books also. People are worried about it. So we come with a similar type of cases. Case-based learning on August 8th. The event is going to happen. Not August 8th, August 15th. We are going to keep in Chennai. This is an hybrid event. If you want to learn all case-based learning, please attend this conference. Thanks for the wonderful opportunity. Thank you, sir. I finished it.
Thank you very much, sir, for a very vivid, elaborate presentation on both the topics. Made it very easier for us. We are, lot of us had, practical doubts. So any questions from the audience? Yeah.
Actually, the most important doubts you cleared was that the human bite, rat bite, bat bite, you need not give rabies. That's a really, really tough answer to the patient. Suppose this bitten by a rat. So that's the point is cleared. And the vaccinated dog, unvaccinated, no difference. You have to vaccinate. That's the point. And all wild animals are grade 3. Grade 3 bites, category 3. So we need to aggressively treat. And of course, equine immunoglobulin anaphylaxis is common, but than the monoclonal antibody. So you prefer monoclonal antibody. So these are the take-home message for the treating physicians day-to-day life. Thank you very much, sir, for a brilliant presentation.
One more time, I want to reinforce: bat bite in India, it's not no. US, even if you found bat in your bed, they give the prophylaxis. India is a different scenario. Nipah is transmitted, but rabies is so far not transmitted.
Thank you, sir. Thank you very much, sir.
For the final talk of the day, so I would like to call upon Dr.G.Ravichandran, sir, MD/DD, dermatology, is a senior consultant Apollo Hospitals and Apollo Cancer Institute, studied from prestigious MMC and Stanley, and he has so much awards and accolades to his name. Professor A.S. Thambaya's centenary celebration oration he has done, and Professor Patrick Yosidian oration also he has performed. Welcome you, sir. Over to you. Thank you.
Very good evening to one and all. Thank you, chairpersons and the organizers. It's late evening. I think I will. My department is very interesting because it's like radiology. It's an image-based speciality. It's a child's play for most of us to play the football match nowadays. Okay, I will just quickly go through. Everybody knows about all these 3 diseases. I thought probably I will give you what is the best to be chosen to that patient, the recent updates. That should be the goal of this talk today. Next slide. Sorry. Yeah. The melanin protects us in many, many ways. But if it doesn't function, it gets destroyed. You get vitiligo. The depigmented patches, all of us know. And we have the different types are there. So I've been doing work for the last 30-35 years on this topic. It's one of the topic we dermatologists must definitely do a good job because it involves impact of life, the quality of life, the girls who doesn't get married, and so many issues starts building up. So this is called the vitiligo. We divide them into segmental and the non-segmental vitiligo. There are different types, as you can see in the photographs there. It's a very interesting one. Do we have an answer? Yes. So we can bring back the color there. How? We are going to see that today. There is no, you don't need a biopsy or you don't need anything else. There may be some family history. The girl to be get married comes there, the mother says, will it go to the family? It is like that. So there's a autosomal dominant inheritance, but it's a very rare penetrance is there. So we have these topical treatments available. All of us use everything all these years with partial results, with good results. And we have the steroids. Tacrolimus was a big boon for us. Then we have the steroids. Of course, steroid phobia is there. Whenever you treat a child with vitiligo, the mother says, no doctor, don't give me topical steroid or oral steroids. And it's a difficult, long drawn problem. Of course, we are able to fix this when it comes very, very early. But the best option now we see is JAK inhibitors. I think most of the specialties use JAK inhibitors. It's a wonderful novel molecule which is very effective in most of the autoimmune disorder, whether it's rheumatoid arthritis or psoriatic arthritis or ulcerative colitis or Crohn's disease. So this is how we do it, and I've been using a lot of JAK inhibitors. I'll show you the results. Okay, if it doesn't respond, we do surgical. So I'm trained in surgical dermatology for so many years. My favorite is I started with vitiligo surgery, but of late I've started doing non-cultured epidermal melanocyte cell transplantation, including culture melanocytes. So this is regenerative medicine is awesome now in every specialty. Regenerative medicine is upcoming so well. So I thought probably I'll give a small tinge. I'm not going to techniques and videographs, which I do it for my postgraduates, but I'm going to tell you the pre and post picture. Then you will believe that there is an answer. Doctor's children may have vitiligo, colleagues may have vitiligo, our children may get. So when you do that, please approach to a correct consultant and do it there. So oral tofacitinib, excellent molecule. We've been using pulse therapy for steroids those days, mini pulse, then the pulse therapy. I think all have been gone away by advent of oral tofacitinib. Tofa is a wonderful molecule, but it has to be carefully used. Okay, we all know that. It's given for non-segmental vitiligo. 5 milligram twice daily is the ideal dose. 6 to 12 months dosage. We have set guidelines to do that. We need to do CBC, LFT, depending upon the younger individual. Very young girl came from Bangladesh, Dhaka, a 15-year-old girl with a difficult vitiligo, and this is after 6 months of a tofacitinib 5 milligram twice daily. She did extremely well. What I have observation is that even after stopping, cutting all the pigments back, the pigments gets retained. Probably it's an immune change. It is not a difficult disease to treat. I am really surprised about this young boy. The mother used to come and cry in front of me. What best I can do? Nothing else. Just a 5 milligram OD started with a 5 milligram BD. Within 6 months he did extremely well. The repigmentation is very uniform and smooth, not like phototherapy, we get follicular pigmentation. This is tuberculosis test is Suresh Kumar was there anyway. We always send them to ID consultant for starting before any therapy. TB quantiferon is a must for all these people. Hepatitis C profile, hepatitis B, for particularly in adults, we have to make sure that everything. And the side effects are very less, very safe, but low platelets, headache, opportunistic infection, viral infections are very common when you do the dosage, and herpes zoster reactivation, mild elevation of lipids, particularly if the patient have an hyperlipidemia. So that is why we do a baseline test for patients who are middle-aged or younger individuals. Women planning pregnancy and lactation. See, we see lots of young girls, women getting married. How can I can't give tofacitinib. Live vaccination, concomitant use of CYP inhibitors. This is a girl came all the way from Bangladesh, Dhaka. From the age of 15 till the age of 25, she had a segmental vitiligo. They tried everywhere, Singapore, everywhere, and she saw my profile and came. I never spoke. At the same day, I put her in the theatre in Apollo Cosmetic Surgery Center. I did a non-cultured melanocyte skin grafting. The post-operative picture is 2 months after that. The uniform, smooth color matching, we got a very good results. It's very selective. We have to choose the patient stable, segmental, focal vitiligo, including lip vitiligo, including fingertip vitiligos, can be easily covered, and it's permanent. This is the topic which we have to be very careful. We see around 4 million people involved with psoriasis. I have my colleagues of doctors with psoriasis. Arthritis is very common in the long run conditions. It can cripple a patient. It can cripple everybody. So you have to be very clear in identifying the psoriasis. The patient comes and tells, doctor, I have psoriasis. Today morning I saw 3 patients with extensive psoriasis. Taken all the drugs, what will I do? Getting married, getting divorced. So this is a quality of life, and very important that this is arises from a complex interaction between genetic susceptibility, there is a genetic play, immune reactivation. After COVID, we saw so many of them with vitiligo and psoriasis, keratinocyte dysfunction, angiogenesis, stress is there, environmental stress is there. These are the factors which really unfold psoriasis. It's a chronic papilloma. We all know the silvery white scales with auspicious sign positive. It's all there. But it can be, now this is a systemic disease. So it's associated with other comorbid. Don't just ignore if your children or somebody comes with a psoriasis, small 1 or 2 plaque or scalp psoriasis. It's a systemic disease from day one because it is associated with obesity, non-alcoholic fatty liver disease, hyperlipidemia, diabetes, coronary artery disease. Moderate to severe psoriasis in middle, I lost 2 patients with cardiac arrest. MI. So be careful, screen them. I get with severe psoriasis, I get a cardiology evaluation for most of them 45, 50, 60. So be careful, it's not that just apply some topicals, emollients or liquid paraffin. You have to be very clear. And arthritis, you have to be very clear. Particularly if nail psoriasis are involved, if there is an enthesopathy, definitely the patients will go for a crippling arthritis of the finger joints. So becomes very difficult if you have to initiate treatment very well. Of course, these are very classical findings. Extensive lesions are there. Scalp psoriasis, very, very difficult. I had few bureaucrats, doctor, I am not going to the court, or wearing a black coat, doctor, every scales are there in my back. So much impact it causes in a different style. The child doesn't go to school. The mother is crying because she can't walk in the kitchen if they have a palmoplantar psoriasis, scalp psoriasis, arthropathic nail, 20 nail dystrophy. I had 2 patients last week. All the nails got destroyed. What will you do? Methotrexate. Anyway, I'll come to the topic of therapy. Yes, topical therapy. For mild lesions, you give topical steroids, vitamin D3 analog like calcipotriol, calcineurin inhibitor, particularly for flexural. Groin itch, 90% is fungal infection, tinea cruris, 10% is seborrheic dermatitis and psoriasis. Very, very important that we got to give flexural, so we can't give steroids because we see lots of patients who are using a topical steroid with antifungal combination in the groin lesion, coming the atrophic thin scar tissue, we even cannot do an angio there, cardiologist. So make sure that never use a topical steroid on the body fold areas, face, eyelids and children at all. Newer topicals are yet to come. The Tapaniraf is just being getting launched this month in India, but I don't know about the efficacy. Okay, this is the drug of choice. Hope you don't get psoriasis. If anyone develops psoriasis, please start as a naive therapy. Not wait till try this, try that. No. One day it's very mild, few plaques. After 6 months, it's going to be very severe, extensive lesions. So biologics are the in thing across India, across the world. We colleagues and myself, everyone is using extensive use of biologics. It's a very safe drug. It is the best drug. Affordability has come very, very well. You can talk to the stockist rate is very 1/3 of the price is given by the stockist. So that is why whenever biologics said it's 20,000, 25,000, 50,000, no. The stockist rate, if you can manage to give the rate, I think it's best available. And we have the, so many conditions are available. I will tell you how to give you. Phototherapy was there, narrowband EVB. I have a patient who bought phototherapy in the home, gone away. Methotrexate still holds very, very good. It's a poor man biologic. It's excellent drug. Excellent, but you have to be very careful. Check the liver, check the complete blood counts and make sure that patient doesn't have any kind of malignancy in the past. Regular follow-up. We give 7 to 5.10 milligram per kilogram per week, along with folic acid supplementation. Once in 3 months, we have to assess them for periodical blood counts. Cyclosporin is a wonderful drug for difficult psoriasis to manage. 100 milligram to 200 milligram, 2 to 3 milligram per kilogram body weight for 4 to 6 months as a crisis buster. Psoriasis clears magic. Today morning I started a patient on 100 milligram BD. So we have to tide over the, you can't straight away afford a biologic. So, but once you start control the disease, clear the disease, we have to change to some other thing. Because methotrexate, particularly biologics therapy, reduces the inflammation in every part of the body. Whether it's the liver, it is the joint, it is the heart. The coronary arteries go for inflammation. That is why patients are prone to develop coronary artery disease. We have to control the inflammation by using these biologics. We have plenty of biologics. I think most of the colleagues must be using biologics in theirs across specialty. We started with Remacade. I will show him a patient's photograph with Remacade. I admitted in Apollo hospitals. He received 6 doses of Remacade. He had a painful plaque psoriasis. Did extremely well. That was 15, 18 years ago. He is still, to my patient, he is still using a biologics. He is still using a newer biologics because of secondary failure, therapy failure. Enbrel is very much available. Etanercept, easy injection. We get it for few thousands now. You can start on the patient. Adalimumab, every orthopedic, every rheumatologist uses adalimumab. Excellent drug, quite safe. I have never seen a reactivation of tuberculosis in adalimumab therapy. It's more useful for joint involvement. Psoriasis, with joint therapy. 40 milligrams subcutaneous once in 2 weeks for 3 to 6 months, subsequently once a month. But if you stop and restart, there is a secondary failure, antibodies develop against adalimumab. So then we need to go for a newer biological, secukinumab, ucikunumab. Okay, these are the maps which are very, very, ucikunumab is very, very effective, secukinumab is very effective, and they are all very costly, but they say that according to Western literature, it's a lifelong therapy. Psoriasis remains lifelong. When it is going to flare up, we do not know. We have to maintain. If the patients cannot afford, if there are no side effects, patients can be rotated to apremilast. It's one of the best drug. 50% of patients do very, very well. It is a PD4 small molecule. We give 10 milligram for first week, 20 milligram for the next week, 30 milligram subsequently BD for as long as they can do. In US, if the patient doesn't come under category of biologics therapy, they switch over to apremilast. So it's excellent. I have seen only the nausea, vomiting, diarrhea is the most common symptom with abdominal pain. So this is a wonderful drug. So we have to be very clear. It affects, all these TNF, all these biologics work by changing the immune system, particularly against the T cells, against the TNF inflammatory IL-23, IL-17, IL-16, 23A. So all these things have to be taken into account. This is how it goes very, very well. Ucikunumab targets, it's all there in the textbook. It's not that. How and when and where to use this, it's a master of art. So we have learned from my patients. I've been using around 50, 60 patients are on biologics now with me for the last few years, and all of them are very, very happy. If the failure occurs, we have to give. Young girl to be married, young man to be married, please, first time visit comes to you with generalized psoriasis, I straight away start. I don't wait for rotational therapy and all. Biologics are going to stay, and it is going to be the future in India. Most of the centers across India, even my colleagues are using biologics left and right. Yes, it is given in subcutaneous form. Those days intravenous. Subcutaneous is all biologics are given subcutaneous. I asked my stockist fellow to deliver to the patient. The patient we teach, he takes the injection like insulin. So easy. It's not a very problematic one. Reassure them. It's very, very clear injections. Very effective, and secondary failures it occurs, switch over to newer biologics. Possible side effects, very, very rare. I have never seen except one reactivation of old latent tuberculosis. Make sure the patients do not have. Okay, this is how cost factor is the only concern. I think India is the best country to get biologics. My patients carry it, abroad patients carry it from ice pack to other countries like Dubai, Malaysia, Singapore, even United States. So that's so effective here. This is my patient from last 20 years I've been following him. I started with Remicade, and now he is on tredelimumab, IL-23 is taking. So this is how the plaque, painful psoriasis. He is like my brother. He says, "Doctor, I'm living because of you." But he's a rich man. He takes the injection, calls the stockist, he injects himself. He clears so beautifully well. And now, last month, he called me that, "Sir, doctor, I have no patches at all." So what we are going to achieve? We are going to achieve a complete clearance of psoriatic lesions. Ixekizumab does the capillar, it's called. Capillar does the job from E. Lilly. So it's a very wonderful drug. If the severity is there, we have to hesitate. We should not hesitate. We have to start. So this patient did extremely well, including the nail psoriasis became very, very well. And that is one. That psoriasis, vitiligo, hair disorder, I don't know. When a patient comes, I don't know what's going to happen to the patient or to me. It's walking on a thorny foot. Nothing can be done. So we talk about hair cycle, we talk about anagen, catagen, all beauty parlors are spread across India, Chennai. You see every place, they go there for hairstyling, hair keratin treatment. Everything is possible now, but they lose hair. What are the reasons for the hair loss? There are many, many losses are there. And before that, I will tell you, okay, we have the definition is there. This is the commonest one, telogen effluvium. Post-COVID, all the women lost hair. We don't know the reason for that. The drugs, fever, post-dengue, post-delivery, post-chikungunya, myocardial infarction, traumatic surgery, pregnancy, accidents, accidents, very common. Then crash dieting. Nowadays the fancy is crash dieting. All can lose hair. It is called telogen effluvium. There is no treatment needed. If any associated hypothyroidism, anemia or deficiency is there, vitamin D, you correct it, but it settles on its own reassurance. Lots of, if you start giving minoxidil, it will worsen more. The patient, doctor, why did you give me? So we don't give minoxidil in telogen effluvium. So this is of course the lady, she did extremely well after that. This is of course as lupus erythematosus anti-cancer drug. This is one. I just wanted to, this is the most important topical, alopecia areata. I have two doctor colleagues of mine developed alopecia, highest stress. An orthopedic surgeon, IT rate, very, very sad. So they get small patches, and then it is, we have the different types are there. We have the totalis, universalis, uffiasis, steroids, sensitizer, puvat, all this minoxidil, everything. But what is the latest treatment? Latest treatment. See, this guy completely lost all the hair. Alopecia totalis. See his hair? The father is crying. So this is the boon again, JAK inhibitors. Tofacitinib. I think most of you must be using tofacitinib. Can you raise your hands who are all using tofacitinib? Yes, I am happy. So it's a good drug. It's a wonderful non-steroid drug. But see, this girl, all they again came from Bangladesh. 5 years of alopecia totalis, lost everything. I didn't know tofacitinib was launched here in India. So I gave her 5 milligram to start with, subsequently BD, and this is after 6 months after therapy. They asked me to come to Dhaka. Maybe I will be received like a king. Okay, so Trofast changes excellent overview for vitiligo, psoriasis, or alopecia areata. Any inflammatory T cell mediated disease, tofacitinib T for T. Those days we used to use tacrolimus for T. All T cells in the dermis, you give tacrolimus. Now we see tofacitinib for all T cell mediated disease, and we have the all of us are bald. I think there is no other choice, and we start at the age of 16. The father is totally bald with a different pattern. You start them quickly, start them on minoxidil with finasteride till the age of 20-25. Because of that time the androgenic influence is there. They do the typical very alpha inhibitors can be given. Finasteride can be given. Carefully, I don't give dutasteride. Finasteride can be given orally if it's advancing alopecia, because it's a very difficult. The boys, the young men doesn't go to work. They get depression, become depressive psychosis. So they didn't get married, they get divorced. So many issues, psychosocial impact. Oral minoxidil is the latest drug. I stopped using topical minoxidil. Messy, difficult to apply, 2 to 3 years. Who will buy and apply? Scaling, irritation, hypotension. If we give for women, they get hirsutism, overgrowth of hairs in the facial hairs. So gone are the days. The oral minoxidil is available for across many companies. We give it for women too. It's not that middle-aged women, perimenopausal, we have to give oral minoxidil. We have the Ludwig pattern, the Hamilton-Bailey classifications are available. 1.25 we start, then increase it to 5 BD for 6 months to 12 months. You can continue as long the patient wants hair. Hypotension, there are side effects are there, but quite safe. Make sure that the patients are not hypertensive. They have to monitor, check vitals. This is, of course, I spoke to my friend today morning. We do a lot of hair transplantation in Apollo Cosmetic along with Dr. Ravichandran. Excellent. We have to select the patient and gives an excellent result. Androgenic, this boy will definitely do very, very well with minoxidil and finasteride combination. And of course, the bitemporal, we have to plan for hair transplantation around follicular unit extraction. Excellent procedure, OPD procedure, so 5 to 6 hours we can definitely do. When the father gets bald, the son is likely to get bald. So pick them early. The school child, never ignore the children that, okay, pa, I'm losing hair. No. If the father and the uncle, the grandfather is bald, it's a genetic transmission. Please be more active. And female also come and cry. They said, what is this? They get really, really depressed. And we have to give topical minoxidil, can be given 5%. And along with the oral minoxidil is the choice of drug. Of course, this is the hair. One of the biggest industry in the world. Biggest aesthetic center. My Professor Tambaya used to say, "A man, you will be on top of the world when you put hair on the bald scalp and remove the girl's chin hair." So we have laser hair reduction and hair transplantation. So this is the kind of scenario. Small hair keratin treatment, women doctors are there, so they contain lots of issues. We talk about minoxidil. Of course, next time maybe invite, I will give a rapid fire of dermatological conditions for 1 hour. This very practical issue in our topic. And hair keratin, I have seen young girls going there spending huge money for hairstyles. Acute kidney injury. If you can check the Google, you will get to know that hair keratin treatments can result in acute kidney injury. Please be aware. Any nephrologists are here, they will definitely recognize. I was called to see acute kidney injury. They couldn't find out the cause, but I picked up because very young, beautiful girl with excellent. I asked her, "Did you go for hair keratin treatment?" I asked her, "Did you pay 25,000 or 50,000? What thing you are talking, doctor?" But that was the story, right? So make sure scenario you have to, because we learned all these years, we've been taught by our professors, seen patients. It's interesting that the topic is skin is the largest organ in the body. What your mind do not know, your eyes cannot see. Thank you.
Three topics, 30 minutes. That's a huge task, sir. And you could be able to cover so many things, new points, especially drugs like TOFA. I think very much exhaustive, sir. Within 30 minutes, I think we got a lot of information on 3 huge topics, practical points. Over to Parandaman, sir. Thank you.
Sir, actually, it's a wonderful presentation. We have learned a lot of practical tips for practice. But what we observed, any autoimmune disorders, the triggered by the infection. Infection triggers the autoimmune antigen, antibody production. So if anything, especially if a T lymphocytes in the skin is more long-lived than T lymphocytes in the other part of the body. If that is the case, the point of giving antigenic treatment like antifungal, antibiotic, anti-chemo, like protozoal, will it help in accelerating the disease, worsening?
As you correctly say, infections can trigger psoriasis or
Yes.
what any inflammatory skin disorders.
Okay.
Those days when we see children with gutted psoriasis, my professor always send them to tonsillectomy, streptococcal triggering factor in childhood psoriasis, gutted psoriasis.
Okay.
So they don't migrate to classical psoriasis. Infections can trigger any inflammatory condition, as we seen in COVID or viral or bacterial, sepsis induced. It's possible.
Yes, sir. What antibiotic you choose in those situations, like skin disorders?
We prefer macrolides to begin with, then cephalosporins, and then anything we can give, sir, depending upon the culture and sensitivity. Staphylococcus is a little risky in certain size, particularly in pediatric population. Staphylococcus in neonates or newborns, Staphylococcus caldus skin syndrome from the umbilical sepsis or otitis media or bullous impetigo. We've been called to see emergency in the children's hospital. We still we are getting. So it's emergency situation. We have an emergency dermatology. Maybe next time I can address that. We have a drug reactions. Most important. I think I'll ask Narra somebody. Drug reactions is the most important for all of us. I have one patient with an Hodgkin's lymphoma, antibiotic-induced Steven-Johnson toxic epidermal necrolysis. 2 months ago, we lost a patient in our hospital with facial trigeminal carbamazepine-induced toxic epidermal necrolysis. Awareness is important. Early recognition is very, very important. Generally, it's difficult for the other consultant to recognize a skin rash. Never, please, if you suspect, the patient comes and tells you, please monitor drug eruptions. I would like to address you one day, maybe in the next chance meeting is given. Thank you so much.
Thank you very much, sir. We will give a big round of applause for the presenter, which wonderfully has enlightened us about the dermatology condition. Thank you very much, sir.
Thank you.
Yes.
All, thank you so much.
We will conclude this CME and our conference. Thank you.
Ladies and gentlemen, with that we come to the conclusion of the DCON 2026. annual conference. It's pretty amazing that how we ended this conference like with an interesting topic, hair and hair related issues. I don't think we ever find a solution for hair related issues, but it was pretty interesting. And I would like to extend my heartfelt thanks to all our distinguished faculty, chairpersons, speakers, and every member of the organizing committee whose efforts have made today's conference a beautiful success. And to present the vote of thanks, I now present Mr. Jai Kumar, Doctor. Over to you, sir.
Good evening to one and all present here. We just finished an excellent conference. I would like to express my sincere gratitude to all our speakers and chairpersons. A special thanks to our D Club President Dr. D. Dhanamithran sir, our organizing secretary Dr. A. Natarajan sir, and organizing chairman Professor Dr. P. Parandaman sir for the immense contribution in organizing this wonderful conference. I also extend my thanks to our organizing joint secretary Dr. U. Mohan sir and the D Club treasurer Dr. Sarath Babu sir. My appreciation and thanks to our scientific committee Dr. Kannan sir, Dr. Jayganesh sir and Dr. Arvind Babu sir. I also thank our reception committee Dr. Kamal Kannan sir, Ram Kumar sir and Vetrivel sir. Also a special thanks to our senior D Club members Dr. Murugan sir, Dr. Arumuli sir, also our new physiology professor Dr. Sendil Kumar sir. Furthermore, I thank the event management and the AV team for the seamless execution and the hotel staff for the excellent food and hospitality. Our heartfelt thanks to the sponsors for the valuable contribution and support. Most importantly, I thank you all the delegates who attended the conference and made it a grand success. So finally, I warmly invite you all to our upcoming D Mantra conference with focus on diabetes in the November 2026. Thank you all doctors. Have a wonderful evening and a great weekend ahead.
Thank you, sir. That was really sweet. And I personally enjoyed today's conference and I found some information quite intriguing. So thank you for including me to be a part of this as well. And I sincerely thank all of the doctors for your service. Thank you so much. Have a great day. Thank you.